I have Tushar Rathod, who is going to present Are we neglecting long-term effects of vertebral shortening on pulmonary function in spinal tuberculosis? Dr. Tushar Rathod, please come over and tell us about your brilliant work on this particular aspect.
Thank you, sir. I feel highly privileged, honored, and at the same time humbled to be part of this year's Young Surgeon Forum. I thank Bombay Orthopedic Society from my bottom of my heart for giving me this opportunity in which I am going to present a work on the effect of vertebral column shortening on pulmonary function in a spinal tuberculosis. Over a period of next 20 minutes, I am going to discuss with certain cases where I am going to place my problem statement of research, the challenges that we encountered, the lessons that we learned, and at the end, I am going to present our results of our pilot study and what is the next that we are looking for. There are no relevant disclosures to be made for this talk. I'll start with the first case. We had a 5-year-old male child who had presented with a progressive kyphotic deformity involving the upper thoracic spine. He was already taking a AKT for 8 months. He had a gradually progressive spastic paraparesis. And if you have a look at an MRI, we are not surprised to see this kind of a MRI at KM hospital where we see this MDR Cox with rampant destruction of the vertebral column. If you can appreciate, his D4 vertebral body is touching almost a D11 vertebral body. So this child at the age of 5 has lost half of his thoracic spinal column. And as there was an indentation on the spinal cord, we proceeded with a decompression and did a posterior instrumentation from all the posterior approach. We could, he recovered the neurology by the day 14. He could stand with support by the end of 3.5 weeks. But by the end of 2 years, if you see carefully, he has not regained much of the trunk length. His breathing is still shallow. And at the end of 4 years also, you can see not much regain in the trunk height. This is like a lockbox. His thorax has become like a lockbox. And the way you have to breathe in a lockbox is shallow and rapid. These kids spend more than 2 times the effort that we spend for a normal breathing in and breathing out of the air. So they lose a lot of calories in that. Their nighttime sleep quality is also poor because of alveolar hypoventilation. So at night usually our muscles are at rest, but they spend more energy. So their daytime quality becomes poor. They become sedentary, and over a period of time they lose a lot of muscle mass. And ironically, if you do a BMI, it will come normal because we are using a recorded height. So one should be very careful to measure a arm span for measuring their BMI to know the nutritional status. Not only the kids below 10 years where our lungs are growing, but also the older individuals, like this female with a 13-year-old female presented to us with a severe axial back pain, difficulty in walking with a precarious neurology. Again, on an MRI, if you see, there is a destruction which is fulminant from D10 to L3 vertebral body, internal salient which is compressing on the spinal cord. These are her pre-op and post-op CT scan, where you can see that there is a preserved posterior elements and a significant destruction of the anterior column, which we instrumented from posteriorly, and we recovered the neurology. But the problem is that we are not able to regain the length of the vertebral column, which is still an issue for us in a long term. These are the post-operative X-ray. You can see that there is a deformity which is going low in the lumbar spine, and this is a pre-op and post-operative comparison. Traditionally, as an orthopedic surgeon, we have been trained to look more at a white. But at the end of this talk, I expect that you also look at a black. So if you see in a lateral view, look at the amount of diaphragm being stretched here. We know that the diaphragm has an attachment up to L1 and L2 vertebra. Post-operatively, that stretching becomes less. You can see the dome of the diaphragm has recovered significantly, which is not the case in a pre-operative period. And we are also not surprised to see this kind of a PFT report when we refer these individuals for pulmonary function testing, that there is a poor exercise tolerance or poor respiratory efforts, so PFT cannot be done. This is the most important slide in my presentation, which basically depicts the 3 stages of pulmonary development in a human being. Normally, we are at peak of our pulmonary reserve by the age of 20. I hate to tell you this, that we start losing our reserve by the age of 30, and between 30 to 60, we lose almost 600 to 700 cc of vital capacity. So imagine if you don't reach to curve A, and if you reach to B, or for verse C, you have a very rapid decline with the aging. What is more important is this Lakshman Resha, this horizontal line. Basically, on the left side, you have FVC% of normal at the age of 20, and this is the age. This Lakshman Rekha varies from the literature to literature between 40 to 60. This is the basic minimum level of pulmonary reserve one has to have. If your reserve are below that, then you have a very high likelihood of succumbing to pulmonary morbidity and mortality if something bad happens. And we have seen in this pandemic, the bad which likely happen is respiratory infections. And depending on your pulmonary reserve, you have a chance to survive as opposed to succumb from it. So my point is that as we are going to age, we are going to lose our pulmonary reserve, and this will not catch up with you early, but over a long time. And how does the spinal tuberculosis affect the vertebral column? If you see this, as you all know, the spinal tuberculosis affects mainly the anterior vertebral column. You get more destruction, you have a preserved posterior column, you get more of an angular kyphosis. And this phenomenon gets much more exacerbated in children, where you lose your anterior growth potential because of disease. So you have a situation where your anterior growth potential is destroyed, your posterior growth potential is unabated. So these children, instead of growing vertically, they start growing horizontally. So not only it's a compromise in the neurological function, but also compromise in your trunk height. For example, this was a 7-year-old kid. You can see what is called as a buckling collapse, because there is a complete cephaloid vertebral border, anterior border is touching the superior end plate of inferior vertebral body. So he's growing more horizontally. We instrumented, we removed the internal salient, but we cannot restore the trunk height back to normal. So the literature or the word is pretty clear. They talked about the reduction in the vertical dimension of the thoracic cage, which is known to affect this. And as you all see, if there is a reduction in the vertebral column, you get a rib which is going to be impinging on the iliac, and you are going to get a costopelvic impingement. We have seen what is a diaphragmatic dysfunction, and over a period of time, these individuals lose their efficiency of intercostal muscles. So with this hypothesis in mind, we have a normal stiffening of the chest wall. With aging, we get a further rigidity in the chest wall because of spinal deformity. On top of that, we try to correct this deformity with a rigid posterior instrumentation, and we end up in losing a significant vertical height of the thoracic column, and that leads to increased respiratory work, decreased exercise tolerance, and hypercapnic respiratory failure. And this hypothesis we wanted to study, so we decided to determine the relation between the vertebral body destruction, the column loss, and its impact on pulmonary function. As we'll discuss in subsequent slide, there's a literature which is existing with osteoporotic and early onset scoliosis, but no such literature is still present with respect to spinal tuberculosis. So we recruited 50 cases of spinal tuberculosis who presented to our institute with a minimum spinal deformity index score of 2, which we'll see in a subsequent slides. We excluded the patients with a lung disease for obvious reasons like COPD, connective tissue disorders, or the patients who had a loss in the vertebral height because of trauma or surgery. And those who are taking inhalers which would interfere with our PFT measurement, or those patients who were in a severely debilitating conditions. We use a semi-quantitative method of Jenant, where the vertebral height loss is characterized by 1, 2, or 3, depending on the vertebral body restriction. If it's less than 25%, 25 to 40%, and more than 40% is given a score of 3. This was done by the single observer. For example, in this case, there's a T11 vertebral body which has destroyed almost more than 40%, score given 3, and T12 vertebral body, so partial destruction, so given a score of 1. Total SDI for this patient becomes 4. All of our patients underwent the pulmonary function test in our state-of-art pulmonary function laboratory at KEM Hospital, where we use a body box plethysmography, which not only calculates the other function, but also it calculates the total lung capacity, which becomes very important in a case the child is not able to do a breathing efforts. We use various spirometry variables like forced vital capacity, FEV1 value, which is the amount of air which you exhale in a first second of your exhalation. And we classified the restrictive lung disease depending on your forced vital capacity, and mild was given a score of 60 to 80%, and the severe was given a score of less than 50%. We use American Thoracic Society classification for obstructive lung disease, where the mild was graded more than 70 and severe was graded less than 59. Whenever the patient was not able to do a breathing effort, we use this DICOM images, where this particular software measures the air density shade of the lung, and it calculates the total lung based on the summation of the thoracic lung volume over multiple sections in a CT scan. So ultimately we get a 3D dimensions reconstruction of the lung, and we get a total lung capacity measured. Another important point which I would like to emphasize upon is that whenever we do a PFT, we get something called as the actual value and there is something called as a predicted value. And your predicted value are derived based upon your age and height. Most of this pulmonary function test center will use a recorded height as a marker. And if you put a recorded height where the child has or an individual has lost multiple vertebral body, you are going to put a shorter height. And your pulmonary function tests are going to become spuriously normal. So it's very important that one has to ask specifically as arm span height as a surrogate marker for the estimation of predicted value. And we know that from pretty ancient period that your total body height is equal to arm span height, and this is a perfect square. Just to emphasize the same thing, we had a 10-year-old female who had a difficulty in walking since 5 years. Defaulter, we had a discharging sinus in the upper back. She had thoracolumbar kyphosis. This is what we classically see: trunk limb asymmetry, longer upper limb and lower limb, but shortened trunk, discharging sinus, and spastic neurology. This is her pre-op X-ray. You can see a spinal canal and an AP view, which means the severity of kyphosis. There was a destruction from D9 to L3 vertebral body with preserved posterior elements. When we end up putting a recorded height, which was 108 centimeter, we got a moderate restrictive lung disease. But when we use a total arm span, the height was 129 centimeter, and you can see the difference in the terms of pulmonary function result. Similarly, same patient, if you can see in a CT scan, again the same thing, you are seeing a significant destruction of the vertebral column anteriorly and a preserved posterior elements which we call tombstones, which are indicative of anterior destruction and a compression on the spinal cord. We do multiplanar reconstruction because a lot of these patients, kids don't have a pedicles to instruments, so it becomes a very difficult job. We removed all the internal salient from the posterior approach. We did a posterior instrumentation. We did anterior reconstruction with the column. This is our post-operative X-ray, improved significantly. These are the post-operative image where we could pull her trunk back to the maximum that we can do. The costopelvic impingement also reduced significantly. We excised the sinus in the same setting. But again, what is the point? My emphasis is that the 1 year down the line, we are not able to restore the trunk height to its normal. Now you can appreciate the breathing she's doing is abdominal breathing. These individuals have a thorax which is completely plastic, and you want to breathe in and breathe out. For that you need a thoracic muscle. One has to create a very significant transdiaphragmatic pressure, so they end up using abdominal muscles to create a ventilation. So a result showed that we had 14 males and 36 females with a mean age of 27.9 years. This is the pulmonary function test result. We had 11 patients with a normal study with a mean SDI of 2.72. We had 12 patients with a mild restrictive lung disease with a mean SDI of 3.83. We had 14 patients with a moderate restrictive lung disease with mean SDI of 5.64. And we had 10 patients with a severe restrictive lung disease with a mean SDI of 6.1. So the point is, as you are getting a reduction in the height of T1 to L5, your lungs are suffering in a proportionate manner. Strangely, we got 3 cases of obstructive lung disease as well, in which 2 cases were a severe obstructive lung disease. So the same point, as your spinal deformity index increases, your restrictive lung disorder severity increases. This is a correlation which we found with the spinal deformity index and forced vital capacity, which was negatively correlated with a correlation coefficient of -3.86. Again, FEV1 value also showed a negative correlation with the SDI. FEV1, again, you have to understand it's a restrictive lung disease, so the amount of air that will be in the lung is less. So the amount of air that you're going to exhale in first second is also going to be less. And that was directly correlated with the SDI, with a negative correlation coefficient of -0.383. The most interesting thing was this. We found that there's a significant and much stronger relationship between the FVC and the kyphosis. As the kyphosis is higher, FVC was lower with a negative correlation coefficient of -0.21. Another interesting thing which we noted was the apex. The apex of the deformity, if it was located in the upper thoracic spine, the restrictive lung disorder was much severe, and FVC ended up in decreasing much more significantly as compared to the apex which was in the lower lumbar or dorsal lumbar spine. So thus the increase in the SDI was associated with the predominantly restrictive pattern. You get a loss of vertical height which causes significant internal displacement of organ and affection of the thoracic muscles to breathe. There's a significant literature which is present for the osteoporosis which discuss about the vertical length from T1 to S1. They have found a linear graded and dose response kind of a relationship between the loss of vertical column height and the impact on a pulmonary function test. The Lenki group last SRS also showed a significant concern even in adult cases. It's not just the kids less than 10 years, but if a deformity sets in the latter part of life, you also tend to get an affection in a pulmonary function test. This study showed, mind you, only 30-degree proximal thoracic curve was affecting the lung function significantly. So traditionally, we've been told that the scoliosis more than 90-degree will affect PFT, but one has to consider the age-related decline in the lung function over the long term. What about the tuberculosis spine? We got this patient from a medicine ward. He was admitted for a heart failure. They did an X-ray. They found a deformity. We were called. This patient had the spinal tuberculosis for which he had taken AKT when he was 34. There was a discharging sinus scar which was present at the back. He had lost almost half of his thoracolumbar region. You can see detail, which is now nearly sitting on L4 vertebra. Significant, again, typical trunk limb asymmetry, distension of the abdomen. He's in heart failure, and these patients have a very poor prognosis. And I suspect that the post-TB pulmonary deformity also have a higher morbidity and mortality. Just because we don't have a long-term data, the cases that we receive at KM is migratory population, underprivileged class. We don't have a follow-up for 30 to 40 years, but just we don't know it, so that doesn't disapprove the thesis. And my assumption is based upon the fact from the early onset scoliosis. The Western literature is very clear. Whenever there's a loss of vertical column height, there's a significant morbidity and mortality in third and fourth decade of life. We don't have that data as of now for a spinal tuberculosis. So pulmonary compromise in our study was associated with a multiple factor, including kyphosis angle, level of kyphotic apex, and the number of involved vertebra. The limitations of our study was arm span being used, the relatively small sample size, semi-quantitative grading, and cross-sectional analysis of PFT. So there is a lot of work which we are still carrying on. We are following this patient for a long term. We are comparing the preoperative and postoperative values. The preliminary data shows there is no significant improvement in the first 2 years, which is similar to the Western population. They also are lacking a long-term study. Almost quarter of these patients improve, quarter deteriorate, and half remain the same in spite of doing a surgery. So understand that your surgery may increase further rigidity and does not necessarily lead to increase in the pulmonary capacity. I had applied for a growth preservation surgery funding for SRS last year, where I received a very favorable consideration from the SRS Research Grant Committee. We are also focusing on the pediatric sample size in isolation with the adult cases. So what next? Is the lung function salvageable? We don't have any data about that. If so, how? We need to do a long-term prospective study. Does lung function improve with certain intervention that others? Yes, there are various cases, open wedge thoracoplasty, growth preservation, but their implication in a spinal tuberculosis is a matter of application, and one will have a lot of logistical and technical difficulty. And is the timing of intervention important? Yes, it's very much important. Earlier you intervene, less is the loss of spinal column. There are certain critical areas which we would like to and which we are focusing on. Main is the intercostal muscle preservation. One need to revisit the rib-sternum relationship, the costovertebral joint integrity. What does this mean? That we should resect the lesser number of ribs when we are approaching the anteriorly and try to preserve that and just not look at the spinal column. The thorax is a fifth or fourth dimension of the thoracic, and this is a domino effect. So the thorax, your lungs, and your spinal column has to be complementary and supplementary to each other, and there has to be a harmonious relationship between these all factors. The diaphragm, as I showed you previously, is a very important, and we are seeing that this diaphragm gets completely stretched because your attachment is in the dorsolumbar region, and when we are correcting this, there's a reduction in the stretching. You have to understand the diaphragm is like a piston. It has to move up and down to suck in the air and suck or the exhale the air. If your diaphragm is abnormally stretched because of your deformity, you are going to lose a lot of respiratory function. Fortunately, when we are correcting this deformity, we are seeing a dome of the diaphragm being restored and the stretching is decreased. We are working on that how much impact does it have on a pulmonary function in the long term. Thus, in conclusion, the loss of multiple vertebrae in TB spine has a deleterious effect on a pulmonary function. It warrants a multidisciplinary approach and not just an orthopedic approach. Your pulmonary function testing should be standard of care, especially in a patient with a multiple vertebral body loss and decline in lung function over time. One has to keep this in mind. And it is very important to address such patients in an early stage before there's a rampant destruction of the vertebral column, because I'm not sure with the current treatment that we are offering whether these kids go to fourth or fifth decade of their life. These are my references. I thank Department of Orthopedics and Department of Chest TB at KEM Hospital for supporting my research activity. Thank you all for your patient listening.
Dr. Rathod, thank you for a very wonderful presentation. Very informative presentation. I have one question. Uh, when there is a lumbar spine involvement, do you still feel and see that there is a PFT derangement is there?
Yes, sir, it's a very important question. Even we were surprised to see the derangement of PFT. There is a lot of literature which has occurred about that, and the theory or the hypothesis is that whenever you lose a lumbar column height, first your diaphragm gets attached to almost like a L1, L2, and you have a significant displacement of internal organs. Your organs, because your lumbar column is very short, your spleen and liver has no place to go, so they push the diaphragmatically upward. It's similarly like a Pickwickian syndrome, which we see in a morbid obesity, where your abdominal content increases, you get a breathlessness. So because of reduction in the vertical column of the lumbar column, you get an internal displacement of organ, which in turn affects the diaphragmatic function.
Your study was restricted mainly to the thoracic spine involvement.
Yeah, sir, we do had a cases of dorsal lumbar and one lumbar isolated involvement.
Okay. Isolated lumbar involvement.
Yes.
I mean, like, you would like to do study on that?
Yes, that's what I was trying to explain, that we are very much interested in understanding the diaphragmatic function. So, Western literature is all about hypokyphosis and early onset scoliosis, whereas the spinal TV is the only disorder which gets a lot of kyphosis. So they are not studying much about the diaphragmatic dysfunction that we are seeing in our patients. Our diaphragm gets abnormally stretched, and I feel that's a significant factor which is causing a respiratory or poor respiratory effort in these patients.
Thank you.
Would anybody would like to ask question to Dr. Rathod? Dr. Rathod, you took up a very obscure subject to study, which requires a lot of dedication, and I congratulate you for that. But with this all information, ultimately, do you see any light at the end of the tunnel? I mean, one look at a person of that deformity, a medical man would say, of course, he can't run 100 meters, that's for sure. But with all this hard work that you're putting in, as a free thought, do you think you will be able to offer them some solution that they can live more comfortably for longer time?
Yes, sir, I get your question. It's very very right question. Now, again, it's not just the longevity of these kids, especially when we are talking about the pediatric population, but the quality of life. These kids, they get alveolar hypoventilation at night, they breathe poorly. There are a lot of literature which has talked about the nighttime positive pressure ventilation, where your alveolar ventilation is being given properly. They are giving it as a standard matter of practice for all the patients with this shortened vertebral column. Second thing is very aggressive treatment of respiratory infections, because we know that we already done a risk stratification, and this kid is a very high likelihood of pulmonary morbidity. So very aggressive treatment of infection. And talking about the surgical perspective from the orthopedic, sir, there are various procedures which are described, like an open wedge thoracoplasty for early onset scoliosis. What they have found is that though you increase the volume of the thoracic cage by doing a Vector or rib to cage, rib to pelvis placement of the implants, you end up increasing the thoracic volume, but that has not proportionately increased the amount of the pulmonary function. So you may increase the thoracic volume, but it may not have a significantly proportionate impact on the pulmonary function. But yes, I feel we end up fusing very long in these kids. Maybe the technical or the revisions would decrease our length of fusion, and thereby we might improve in the amount of salvage that we are going to do with a thoracic column height.
Do you think when the patient is in wet stage, if we institute some measures like active pulmonary exercises or something like that, that may come out of this, that may have a beneficial effect on their final recovery and quality of life?
Yes.
You see any data coming out of your study?
Yes, sir. What we are looking at is right point is that the wet stage, what we are doing is a hollow thoracic splintage. When we give a hollow splintage to the patient, we try to pull out his thoracic, the hollow skull traction. When we give it in a wet stage, it tries to pull his upper thorax back from the neck, and they get a significant improvement in the pulmonary function test. But still, my data is still underpowered to comment on a long-term perspective for that.
Any data on a longevity or increasing the life expectancy?
Yes, sir. That's what my emphasis is, that we are in India lacking in a long-term perspective. They have a registry system where they are following for the patients for 30 to 40 years. What we have a data, why my index of suspicion for high morbidity in this patient is based upon the fact on early onset scoliosis data. And that is also limited, where they show that significantly increasing the mortality by 40 to 50% in a 4th decade of life. But we don't have data just because we are not recorded this as of now.
Thank you very much.
Thank you very much.
Please come over and collect your certificate. ऑफिस यहाँ तमें आप
Please. Yeah, any question from Hall B?
Yes, Dr. Tiwari, would like to hear you. No, sir. Just hold on a second. You're not being heard in this hall.
Hello.
Yeah, we get you.
Actually, here there is already deformity, and I want to know before surgery what was PFT, and after surgery was there markedly decrease in PFT. So, what causes this shortening? Already deformity has decreased the PFT, and little shortening correction has further decreased the PFT. Is it so? And if it is so, why? How?
So whatever I could gather from his voice is that whether there's a significant improvement in the post-operative period that he's asking. So my answer to is that for the first 2 years of post-surgery, we don't see a significant improvement. What we are seeing is a trend. We are seeing certain individuals which are responders, they are improving a pulmonary function test significantly following a surgery. And there are certain which are non-responders. So we are understanding the attributes of each of them. The second thing is that whenever we are stretching down the kyphotic apex and when we are relining the column, we know that cord doesn't tolerate the stretching much well. We have to shorten the column because it's very risky for a cord. We cannot stretch it to much longer extent. So what happens is that we end up in losing the trunk height, but we reduce the amount of angular kyphosis. And my study has shown that kyphosis amount is much more significantly related with the amount of reduction in the force vital capacity. So it's not just the spinal deformity reduction, but the angular collapse, which is also very important when one is seeing the pulmonary function test.
Thank you for the answer. Dr. Tiwari, I see you want to ask more questions, but I'm being told by the governors of this meeting to wind it up. So Dr. Rathod is available for you to answer all your questions later. Thank you for Dr. Rathod, and thank you the audience for having a patient listening.
Thank you very much, Dr. Rathod. Thank you very much, Dr.